Good evening, everyone. On behalf of the Sri Lanka College of Specialist Family Physicians, I warmly welcome you all to today's CPD event on the management of chronic kidney diseases in primary care. CKD is not only an important topic but also a timely and a relevant one. And in Sri Lanka, the burden of CKD has been a growing concern, and there is an urgent need for awareness and also effective management at the primary care level as well. So, without further ado, let me introduce today's resource person, Dr. Buddhika Illeperuma, consultant nephrologist at District General Hospital Matara. Dr. Illeperuma is an expert in the field, and we are honored to have him here with us today. Sir, on behalf of our college, I extend my warmest welcome to you and look forward to your insightful session today. And before we begin, please allow me to take a moment to go over some housekeeping rules for the session. Dear participants, please make sure to rename yourselves with the Zoom name similar to the one you expect to appear in the participation certificate. And towards the end of the lecture, a link will be shared in the chat box. Please fill out the provided form. And note that attending the lecture for at least a minimum of 45 minutes and completing this form is necessary to obtain the certificate. And during the session, please keep your microphones muted throughout the session. And if you have any questions, kindly type them in the chat box and they will be addressed later. And I would also like to remind you that you can subscribe to the official YouTube channel of Sri Lanka College of Specialist Family Physicians because in that channel you can see the previous lectures, recordings of the previous lectures. And information regarding the next CPD activities will be shared through our WhatsApp group. So now I invite Dr. Buddhika Illeperuma to commence his talk. Sir, over to you.
Right, very good evening to all of you. I hope you all can hear me. Is the voice is clear, Sindhuja?
Yes, sir. Clear.
All right, okay. Thank you very much. And at the outset, I would like to thank Sri Lanka College of Specialist Family Physicians for inviting me to deliver this lecture. And also, I would like to thank you all for joining this important lecture. So, the today's topic is management of chronic kidney disease in primary care setting. So we'll move into the lecture proper. So before going into the core of the lecture, I would like to discuss few of the basics because without knowing this stuff, we won't be able to understand what's there in the core of the lecture. So let's refresh our knowledge about basics of renal physiology. I mean, the serum creatinine, as you all know, the key renal function marker we use. There are normal ranges for serum creatinine. There are two sets of units we use to measure serum creatinine. You would have seen serum creatinine reports being measured by milligram per deciliter, which is being commonly done by the private sector, especially. And there are some government hospitals, they measure creatinine by milligram per deciliter. So that was the older units. And some of the government hospitals, including the national hospitals, starts giving reports from micromoles per liter. So in milligram per deciliter, for a male, the normal range of creatinine is around 0.7 to somewhere around 1.3. And if we translate that into micromoles per liter, so that would be 60 to 120 for a man. And for women, the normal range from milligrams per deciliter is like 0.6 to 1.1. And similarly, from around 55 to 100 micromoles per liter. So the importance of knowing these two units are you will see the reports coming from various sources whenever you are managing patients in primary care. So one report you will see from milligrams per deciliter, and the next month report would be from micromoles per liter. So you will be in a dilemma to how to interpret and how to know the progression of creatinine by using these two different sets of units. So it's easy to convert between these two units. That's today's first lesson: how to convert milligrams per deciliter to micromoles per liter. So that is, you multiply it by 88, quite simple. So if you get a creatinine report of 1 milligram per deciliter, it would be somewhere around 88 micromoles per liter. And similarly, if you want to convert the other way around, like from micromoles to milligram, you divide that by 88. So a simple math. And so, and also we use another special investigation when it comes to screening of chronic kidney disease, that is urine to albumin creatinine ratio, fondly called as UACR. That is to measure the amount of protein urea. So this is also sometimes very confusing because some of the labs use different sets of units, but usually there are two sets of units we use for urine albumin creatinine ratio less than 30 milligrams per gram of creatinine. That is less than 30 of milligrams per gram, and if it is less than uh, if it is be measured by milligrams per millimoles, that is the limit is 3. So anything below 30 milligrams per gram is considered as normal, or else anything below 3 milligrams per millimoles considered as normal. So that's to reduce the confusion during the lecture. So we'll move on to the next part. So the today's topic is chronic kidney disease. So what is chronic kidney disease? So that is being simply defined as abnormalities in kidney structure or function. So there are two components, mind you, that is structure or function, present beyond 3 months and with implications for health. So all these components are important because it should be there for more than 3 months. So anything which settles within 3 months is considered as acute kidney injury. And if something persists beyond 3 months, any renal damage, that is considered as a chronic kidney disease. So why this 3 months cutoff? Because after 3 months, the fibrosis sets up. The reversibility of the injury becomes less and less beyond 3 months. So whatever the injury happens, initially it would be inflammation, but later on it will be fibrosis. So once it is fibrosed, it will be irreversible. So that's why this 3 months cutoff. And the third part is extremely important because there should be implications for health. So otherwise, we don't categorize any number or anything as chronic kidney disease without implications for health. So that's the definition given by K. Daigo, that is kidney disease implications of global outcome. That's the standard guidelines we use, K-DIGO guidelines. So that's the definition given in K-DIGO. So as I said earlier, so either there should be markers of kidney damage. So if we are to tell whether somebody is having chronic kidney disease, there should be markers of kidney damage, or else there should be a low glomerular filtration rate, so that we call as GFR. So we'll talk about GFR later, but so if we are to categorize chronic kidney disease into these two components, either you should see a low glomerular filtration rate. The definition says GFR less than 60 milliliters per minute is categorized as chronic kidney disease. So GFR above 60 are categorized as chronic kidney disease only if the markers of kidney damage are present. Now, I'm repeating that statement because this is one of the most confusing parts whenever you see a chronic serum creatinine report, whenever you see a eGFR report. So eGFRs of 80, 70, 85. So is this chronic kidney disease? So what definition says, when your eGFR goes below 60, so that is definitely considered as chronic kidney disease. Any eGFR above 60 will be considered as chronic kidney disease only when the markers of kidney damage are present. Okay, so what are these markers of kidney damage? If there is evidence of albumin urea. So usual healthy person excretes albumin less than 30 grams per day for a whole day. Or else, as I said earlier, the urine albumin creatinine ratio in a healthy person is less than 30 milligrams per gram. So urine albumin creatinine ratio is calculated by using just a single urine sample. So that's why you get a lesser number, 30 milligrams per gram UACR using a single urine sample. But if we collect urine for 24 hours, and if that 24-hour sample shows albuminuria more than 30 grams, so that is also abnormal. So nowadays, we don't collect 24-hour urine samples any longer because UACR is very simple. We use just a single urine sample. So anything above 30 shows there is some evidence of kidney damage because albumin is leaking through the kidney. So to make it simpler, if your GFR is, say, 80, so it is above 60. So just by GFR, you can't diagnose CKD because it is above 60. But in a patient with GFR above 60, and if their urine albumin creatinine ratio is above 30, so that shows the evidence of kidney damage, even though the GFR cutoff is above 60. So that person will fall into CKD category. Similarly, if there are evidence or if there are sediments in the urine, so sediment means when there are especially red cells or red cell casts in the urine, that might indicate kidney damage. So that is also categorized as a marker. If there are electrolyte abnormalities, like it could be hyperkalemia or it could be hypokalemia. So likewise, if there are uh, electrolyte abnormalities due to kidney disorder, so that also we can take as a marker of kidney damage. And if there are histological abnormalities, for example, if you do a kidney biopsy and it shows like fibrosis or any abnormalities in the histology, that is also categorized as a marker of kidney damage. And if there are any structural abnormalities like hydronephrosis or dilated ureter, or if there is a stone, so that is also considered as a structural abnormality. So that would account for a mark of kidney damage. And anybody with a kidney transplantation, by default, we say that patient is, because he already had kidney damage in the past, and having a kidney transplant is automatically categorized as chronic kidney disease, even if the kidney is functioning well, because that kidney is, and there are health implications having a kidney transplantation, even if their eGFR is normal. So that's why these are considered as markers. So I hope this is a very clear message that if somebody wants to diagnose chronic kidney disease just by using GFR, so it should be less than 60. Anything above 60, it could be CKD when there are markers of kidney damage. And so what is a normal eGFR? So usually the normal healthy adult, we consider the GFR is, in a young adult, considers around 90 or above, GFR is normal. Okay, so 90 or above GFR is normal in a young, healthy adult. So then, so what is between 60 to 90 then? So why this cutoff of 60 instead of 90 to diagnose chronic kidney disease? So there are reasons for that. So we'll discuss. So why GFR 60 to define CKD? So by doing extensive studies, it has been shown that GFRs below 60 are associated with significant health implications. So you can remember the definition. So chronic kidney disease is structural or functional abnormalities which causes health implications, right? So anybody having eGFR 60, they are having an increased risk of cardiovascular disease. They're having an increased risk of all-cause mortality, and they're having increased risk of metabolic complications of chronic kidney disease. And they can get drug dosing problems when they are, antibiotics or other medications. They are going to get problems, especially when their eGFR is less than 60. So that's why this eGFR cutoff 60 came. Okay. So to clarify this more, if you can clearly see, this is a very famous graph. This graph was in fact drawn in like 80s, where a large population of healthy individuals being pooled, and their glomerular filtration rate was calculated by using a special agent called inulin. So if you can remember the basic physiology from the medical school days, you might remember this inulin business, because we measure creatinine to measure kidney function, but creatinine is not a 100% suitable molecule to measure kidney function, because um, by measuring kidney function, we would like to comment about the glomerular filtration. But creatinine is not solely excreted through glomerular filtration, but it is being excreted through the tubules as well. So about 1%. So that's why the creatinine is not considered as 100% good marker of glomerular filtration. But in the practical setting, it is something produced from the body. So we use, that's the best available for us. But inulin is an external molecule which is being injected into the healthy individual, and the inulin is 100% excreted through the glomerular filtration. So if we measure it in the urine, you will get a exact idea about the glomerular filtration. So that is the best molecule, but that is not a natural molecule. So you need to inject it and measure it. So that's why we no longer we don't use it in the healthcare setup, inulin, but in the laboratory setup, inulin is the best. So they have injected insulin to healthy individuals in various age groups, and they have measured the inulin clearance. So that would give the exact glomerular filtration. Now you can see, if you see the left hand half of the this graph, the left graph, it shows the inulin clearance of men from the different age groups, starting from 0 to going on to 90. You can see inulin clearance cutoff of 60, and most of these dots are above 60, right? So, and these are all healthy individuals from different age groups. Only there are few people at the extremes of age, in their 80s and 90s, there are values below 60, but otherwise everybody are above 60. So this is one of the observations which aids to define CKD from eGFR of 60, because eGFR 60 to 90, as I said earlier, healthy young individuals can have 90, but 60 to 90 can persist. It can still be normal in healthy population. So that's why this number came. And you can see the right-hand graph of women, almost everything is above 60, right? So that's how this number 60 came, and that is being used to define CKD. And if you see this graph, so this depicts the mortality associated with eGFR. So the x-axis starts from 15, and the extreme corner of the x-axis, it shows the 120. So that is the completely normal eGFR. So it is above 90. 90 to 120 is the normal GFR for a healthy young person. But if you can see, when their GFR drops, then they are, until like somewhere around 75, the mortality remains same. And then after passing 75, it starts gradually rising, and after 60, it starts rising rapidly. So that's why the EGFR, beyond EGFR cut of 60, your mortality rises. So that is the clinical implication of CKD. So one indication to put EGFR 60 to define CKD. And what about UACR? So I said UACR more than 30 is to define CKD. Similarly, you can see these two graphs. So the mortality has been depicted against the UACR. Once UACR rises somewhere around 10, the graph starts sloping, and then beyond 30, the mortality increases. So that's why eGFR 30 and UACR, sorry, eGFR 60 and UACR 30 came as a definition. So this famous color graph has to be kept in your mind. So we define CKD by using both GFR on one side and by using albuminuria on the other side. So if your eGFR, so this graph says G1. So G1 means uh, chronic kidney disease category, category 1. So if somebody's GFR is above 90, and their albuminuria is 30, they are considered mostly normal, but they can have chronic kidney disease if there are other markers of damage are present, like red cells or the scan is showing any features of damage. Still, they can be defined as chronic kidney disease stage 1. But as it goes on, we categorize chronic kidney disease into stage 1, stage 2, stage 3, 4, and 5. So stage 1 is eGFR above 90, but they are having normal proteinuria or elevated proteinuria. So eGFR 60 to 90, we consider it as CKD2. As I said, not just by not just by eGFR, but there should be other evidence of CKD. But if your eGFR falls below 60, so that is CKD3, even without other areas of damage, you be considered as having CKD. I hope this is clear. And you can clearly see the eGFR, as eGFR falls, your mortality increases. And also as your albuminuria increases, your mortality hugely increases. So that's the basic definition of CKD stages, which you can refer later into this graph and get yourself familiar with. So when it comes to CKD management in primary care, there are key concepts. So when to screen for CKD, what to do after diagnosing CKD, and when to refer to a nephrologist when you diagnose CKD. So during next few minutes or so, we'll discuss and try to find the answers for these 3 questions. So screening for CKD. Now you know how to screen for CKD. So we need to find out the eGFR and also whether there are any other markers of kidney damage. So simple thing is to get the serum creatinine, and we'll discuss how to calculate eGFR in next few slides. And then other simpler investigations available are urine full report. So if you are having a doubt whether somebody is having chronic kidney disease because they're having risk factors, you need to do all these 3 investigations. You do a serum creatinine, and you need to do a urine full report, and you need to do a urine albumin creatinine ratio. All 3 will give a comprehensive set of screening, because urine full report, as I said earlier, so you have proteins in the urine full report. But in order to be diagnosed in the urine full report, usually you need to have quite a significant amount of proteinuria, right? So usually it should be somewhere around 300 milligrams per gram. So then you will get a plus in the UFR. But anywhere between 30 to 300, you won't be able to diagnose by UFR. So you need to do a urine ACR to diagnose that. So that's why UFR alone is not adequate. But what's the importance of UFR? You can see the sediments, the red cells, red cell cast. So if they are there, that is also indicative of renal damage, right? So the next step is, once you get a serum creatinine value, you need to calculate the eGFR using an online calculator. So you need not to wait until now. Nowadays, our serum creatinine reports will be combined with an eGFR value underneath the creatinine report from standard labs. From but some of the labs, they don't give the eGFR value. Now you are in a predicament to know that how I'm going to diagnose the eGFR, which is very simple. You all are having smartphones. So I'll just quickly skip into the next slide. So what you need to do is you can calculate the eGFR by using an online eGFR calculator. So you search the word eGFR in your App Store or Google Play Store, and you will see this icon like a kidney bean in the orange color. So that icon, that's the top, the search finding. So the topic, it will show as eGFR calculators, National Kidney Foundation. So if you search this and you will find the eGFR calculators, National Kidney Foundation, you install that app in your phone, and then you will be given an interface like this, right? You can see that on your left-hand side, it says there are lists of formulas given. It says National Kidney Foundation, and then at the top, you can see an equation called CKD EPI creatinine equation 2021. So you need to click that, and then you will be moved to the right, the interface shown in the right side, the CKD EPI creatinine equation. So it's a very simple thing. You can see that there are a few boxes to fill. We have serum creatinine, right? So, and then the units have been given as milligrams per deciliter. If you click that downward arrow, you will get micromoles per liter. So whatever your result says, you can just enter. If it is 1.5 milligram per deciliter, you just type 1.5 there, and then downwards you enter the age, right? Age of the patient, and then you click the gender, and then you will automatically get the eGFR results. It's a very simple thing. All of you, everybody who is practicing medicine should have this calculator in your phone installed, and instantly you will get the eGFR value. You need not to wait until lab says your eGFR value. And you again, going back to your left hand interface, there are other equations as well. Revised bedside squats formula, that is for people below the age of 18 years, for pediatric and the teenage population. So you use CKD EPI equation for anybody 18 or above. And there are some other formulas we'll discuss later on. But so this is the simplest way of calculating the glomerular filtration place. So why this is called as eGFR? What does E stand for? So E is estimated GFR, because this is not a calculated GFR. Because if you are to calculate the GFR, what you need to do is you need to collect a 24-hour urinary volume, and then calculate the creatinine in that 24-hour urine volume, and there is a formula to calculate the GFR. So that is called as calculated GFR. So, but collecting 24-hour samples are very cumbersome. So you take just a single creatinine value and you estimate the GFR, which is more or less good enough for clinical practice. Okay. So moving back to our previous slide. So you screen for CKD by using creatinine, UFR, and UACR, and then you estimate eGFR. And then what you need to do is you confirm your eGFR, whether it is less than 60 or not, right? And are you going to diagnose CKD by using just one creatinine value? No. So that is the next message. Whenever you get a high creatinine value, you need to repeat that, because there are a lot of other confounding factors which can change your creatinine. And especially the marginally high creatinine values, the things like 1.3, 1.4, 1.5 kind of creatinines, sometimes are, sometimes to do with their fluid intake, or maybe something to do with their medications, or say their exercises. So you always need to repeat your creatinine whenever you find an abnormal creatinine, you repeat it and confirm. So rather than just sending an 1.3 creatinine straight away to a nephrologist, it's your duty to repeat it, say in another visit, some within 2 weeks, and confirm whether this is normal. So if the next report comes as completely normal, okay, okay, fine. So something would have been physiologically abnormal at that point earlier, but now it is again back to normal. So we'll keep an eye on, and you might repeat it in another few weeks' time, and just to double check whether things are perfectly all right. So likewise, you repeat it and confirm. So if the next eGFR is also, less than 60, then you can think that, okay, likely there is a likely problem, right? And also you need to keep this in the mind. There will be a biological variability of serum creatinine. Your serum creatinine does not stay at the same place. So one day it could be 1.1, next day it could be 0.9. So next day it could be 1.3, depending on your fluid intake. So somebody is having serum creatinine from zero point 0.9 to 1.1, we don't diagnose them as having a rising creatinine. And anybody with 1.1 to going back to 0.9, it is not an improving AKI. So it's a normal variability, right? So that's you need to keep that in the mind. But if there are huge changes of creatinine, so that is being considered as a significant changes of creatinine. And if you diagnose couple of values of high creatinine, as I said earlier, you repeat it again, say uh, within 3 months, and confirm whether this creatinine, what is the creatinine pattern. All right. So, as I discussed earlier, creatinine sometimes can be misleading in certain sets of people when you are trying to diagnose chronic kidney disease, because creatinine depends on your muscle mass. People with very low muscle mass, so people who are cachectic, they can have low creatinine values. So sometimes if you try to measure eGFR by using their creatinine values, they will give a false eGFR. So there is an alternative to serum creatinine called cystatin C, which does not depend on your creatinine, which is a better value when your muscle mass is abnormal. Either it is abnormally low or abnormally high, especially people who are doing uh, bodybuilding where their muscle mass is high. They can have marginally high creatinine values. Even young, healthy males with huge muscle masses, they can even go up to 1.5 creatinines, which could be absolutely normal. But when you are unsure, you do a cystatin C level, which is a bit of a costly affair. But you can get a cystatin C level done from any lab. And so there is, if we go back to this online eGFR calculator, on the left interface downwards, you can see there is an equation called CKD-EPI, creatinine cystatin C equation. So if you are in a doubt with regard to the muscle mass, you get a creatinine as well as cystatin C and calculate the eGFR by using both. So that will give a better results. But otherwise, in a usually healthy male or a female with reasonable muscle mass, you just calculate eGFR by using serum creatinine. So I hope these basics are clear. So the next slide shows the different indications. So I think the most important the slide of this lecture would be the current slide, because as I said earlier, chronic kidney disease is extremely common. As you all know, at this particular moment, almost one third, about 30% of the Sri Lankan population are having diabetes. So it was 25% few years ago. There is an alarming rate of rise up to 30%. And usually up to one third of these people with diabetes are having hidden chronic kidney disease. So you can imagine the burden of chronic kidney disease in the society. Usually, it's about 10% of the population are having chronic kidney disease. You can imagine the number of people having chronic kidney disease in Sri Lanka, the 10% of the population, but in certain areas, it can go even up to 15 to 20%. So where are these people with CKD? They are hidden in the community. And as you have been taught in the med school, the unfortunate thing about chronic kidney disease is you don't get symptoms until it gets very advanced. And most of these people present to us or to the nephrologist or to your primary care when they are having symptoms where their eGFR is usually well below 30 or 25, or they are about to start dialysis or renal replacement therapy, which is an extremely unfortunate thing to happen, because Sri Lanka is a country where we can't afford renal replacement therapy because of our economical status being a low middle income country. So it's the duty of the primary care physicians to screen for chronic kidney disease and diagnose them early, because whatever the etiology, either it is CKDU, either it is diabetes, or either it is chronic kidney disease due to stones, there are lots and lots of things we can do to prevent their progression and letting them ending up in end-stage kidney disease where they are becoming helpless and they are becoming a burden to the Sri Lankan healthcare system. So it's your duty to identify the people who should be screened for chronic kidney disease. So you all will be managing loads of people with diabetes. Now think today, and how many of you have done a creatinine value annually in your patient with diabetes? Sadly, it will be less than 10% of your population are doing serum creatinine annually, regularly in your diabetic patients, if I'm correct. So we'll be seeing loads of patients who are having diabetes being nicely followed up for years and years, and they are coming with creatinine of 5 and 6, and coming at the end stage of their kidney disease, which is a very pathetic and sad situation. So it's your duty to screen these people, especially diabetes, which is the commonest cause of chronic kidney disease in Sri Lanka and elsewhere. Every diabetics warrants CKD screening annually. Everybody should undergo serum creatinine and UACR annually, irrespective of their age. Everybody with diabetes. So that's a must. What about hypertension? The second most commonest cause of chronic kidney disease worldwide is hypertension, which is a very, very less regarded cause of hypertension, cause of chronic kidney disease. You have to screen them. Anybody with chronic hypertension should be screened for chronic kidney disease, usually 1 to 5 year intervals. So 1 year interval, I mean, annually you have to screen if their blood pressure control is not adequate. But if their blood pressure control is adequate, 1 to 5 year intervals, at least 3 hours, 3 yearly, or at least 5 yearly, you have to screen them for chronic kidney disease and refer them accordingly. People with history of acute kidney injury, you have to screen them, because even though they have recovered from the acute kidney injury, for example, imagine a patient who had leptospirosis or a snake bite, who had an acute kidney injury, now their creatinine and eGFR is completely normal. But during the phase of acute kidney injury, they have sustained kidney damage, and they can have chronic kidney disease in the background hidden, because your creatinine goes up, only your 50% of the kidney gets damaged. So you know that. So their creatinine could be normal, deceptively normal, but they can still have chronic kidney disease. You have to monitor them annually, at least for 3 4 years after a episode of acute kidney injury, to see whether they are developing chronic kidney disease. Anybody who had acute kidney injury are at risk of developing CKD, irrespective of the cause. And doctors who are from CKDU endemic areas, like dry zone, the northeast, the eastern province, and southern province, the Hambantota, Montreal, and those areas, and also Putlam, Kurunagal, those areas, they're the dry zone. CKDU is endemic, and people, irrespective of their age, if they are living in an endemic area, you have to screen them manually with CKD for CKDU with serum creatinine and urine albumin creatinine ratio. What about cardiovascular disease? You will never imagine cardiovascular disease itself is a cause for chronic kidney disease. If your patient is having ischemic heart disease, even though they don't have diabetes or hypertension, they should be screened, right? It may not be annually, but at least 2 to 3 years, you have to do a creatinine, and make sure your patient who are having cardiovascular disease, at least they have had a one creatinine in their lifetime. That would at least fulfill your duty as a primary care physician. Obviously, people with renal tract disease, calculi, your benign prostatic hyperplasia, you have to do creatinine. Family history of any kidney disease, you have to do. If your patient is on NSAIDs, prescribed maybe by a rheumatologist or maybe by a orthopedic surgeon, you have to monitor their creatinine. Drugs like lithium and sulfasalazine, they are known to cause renal damage. You have to screen them. Anybody with a solitary functioning kidney, they are at risk of developing CKD. So you need to monitor their kidney function to diagnose chronic kidney disease, right? So now imagine now you have your ischemic heart disease patient, and as I said, you did a creatinine value. Fine. So, and then you get a say eGFR. You did one creatinine and you got an eGFR value of 50, and then you repeat it in another week's time, and you get again it is 50. Fine. So is this CKD? So how to answer that question? So could this be something else? So as you all know, elevated creatinine can happen in the setting of acute kidney injury as well. So then how to label this as our topic of interest for today is CKD, but you need to know, you need to exclude acute kidney injury whenever you see a high creatinine value, right? So how do we exclude acute kidney injury whenever you get a high creatinine value? So usually the causes of acute kidney injury uh, um, in the community, like say example, maybe a patient might be on a drug like NSAID, right? Patient might be having a febrile illness. It might be a patient at the onset of leptospirosis. So usually, the rule of thumb is you ask from the patient, are you feeling all right? Are you well or ill? So if your patient who are carrying a high creatinine report says, no, doctor, I'm not feeling very well over last few days. So that means probably patient is having some acute illness, isn't it? So then in that particular setting, your creatinine value might indicate acute kidney injury. So that's the simplest way to diagnose that. Okay. So to find out whether the patient is having any symptoms, if the patient is feeling completely well with a high creatinine value, so then this might be chronic kidney disease, right? And in this setup, you need to remember that our patients are commonly on NSAIDs due to various reasons. NSAIDs can temporarily elevate your creatinine in milder numbers even without a significant kidney damage. So this is a very important message. So, for example, if you take, say, a few tablets of ibuprofen or diclofenac for few days, say for a joint pain, and if you measure your creatinine during while on NSAIDs, you might see your creatinine as 1.3 or 1.4. So that does not indicate you are having a renal damage. But once you stop your diclofenac, it will automatically within the next 24 hours or so, it will come back to a normal value. So that is because NSAIDs causes renal vasoconstriction. All right. And then once you stop NSAIDs, the vasoconstriction disappears. So that is a very common thing. It does not indicate renal damage. Right. So that's why whenever you see a high creatinine value, and next question you need to ask, are you on any painkillers? So if this is not paracetamol, but this is NSAIDs, so yes, sir, yes, doctor, I'm on a diclofenac. So okay, fine, don't worry. You stop your diclofenac, wait for a few more days and repeat creatinine. Right, rather than just alarmingly refer this patient to a nephrologist. So if it is normal, okay, you know, this is a reversible thing. No need to worry. And but is that an indication to not to give NSAIDs? No, not really. So NSAIDs, uh, 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 these are very useful drugs. So that's not an indication. You can give NSAIDs, but NSAIDs has other means of kidney damage where it does not improve after stopping NSAIDs. So then there are other means. So then you might not be able to give NSAIDs in the future, but somebody who improves rapidly, that is not a problem. So you can give NSAIDs, right? So that is one way to approach your creatinine. So the next most important thing, whenever you diagnose a creatinine value, you turn the pages of your clinic book and see whether this patient has had any other creatinine values done in the past, which is a very handy thing. So if your creatinine is say 1.6 or so eGFR is 50. Now you are in a doubt whether this is an AKI or CKD. You go through previous records, and 3 months ago, the patient is again having a 1.6 creatinine. You turn the pages more. 1 year back also, patient is having a 1.7. Now you know absolutely this patient is having CKD, but he is very stable chronic kidney disease. 1.6 even 1 year back. So it is just stable CKD through. So there is no hurry to refer to a nephrologist urgently because you know this is mild CKD. So you need to leisurely approach this patient. So that's how you diagnose the chronicity of the patients. And the next most important thing, so these things are being listed according to the importance, whether there's an acute illness, how about the past creatinine values, and then does your patient has any risk factors for CKD? Absolutely important. So you do a creatinine in a diabetic patient and you find out your creatinine is 1.5 and patient is completely asymptomatic, you know he is likely going to be some kind of diabetic nephropathy. And because especially if your patient has been having poor glycemic control in the past, you know this is going to be CKD likely. What you need to do is leisurely repeat the creatinine values in couple of weeks time, so that if that shows the similar value, you repeat it in another month's time and see, okay, how is the progression. Okay, so it is staying at 1.6, patient is diabetic, so then you know this is likely going to be CKD, stable CKD to diabetes. So likewise, that's how you evaluate the chronicity. You repeat the values always. So then, if you want to establish the chronicity in detailed investigations, you need imaging of the kidneys. So you can order an ultrasound scan of the kidney to find out kidney size. So that's the most important thing. So how your kidney size is going to be important in a patient with chronic kidney disease, because some of the patients with chronic kidney disease, they can have the smaller kidney size. So usually in a healthy male, the kidney size is somewhere around 11 to 13 centimeter. But if it goes below 10 centimeter, we consider it as a small kidney. In a female, if it is less than 9 centimeter, they are considered as small. So if your kidneys are small, then it you know that kidney matter has gone down. So this is definitely chronic, isn't it? So in acute kidney injury, your kidney size does not go down. If the kidney size is small, so it is chronic kidney disease. It is very important to find out the chronicity. But the important message I should give this at this point, your diabetes diabetic nephropathy, or diabetes causing chronic kidney disease, your kidney size stays normal. So that's the message of the day. Your creatinine can be 500, 600 micromoles per liter, but your kidney size will be normal in your diabetic nephropathy. So you can't diagnose CKD just by having a normal size kidney and say, okay, my diabetic patient is having a creatinine of 200, but his kidney sizes are normal. So this cannot be CKD. There is nothing like that. So your kidney size will be normal in CKD with diabetes. So it's very important. And then the kidney pathology is the next thing. So the message is, do not assume your high creatinine value is always CKD. Okay, so that's the message. You might have missed a patient with AKI. So you get a history and repeat the serum creatinine and find out whether your creatinine is rising or not. Then if it is stably high, then you might be dealing in the patient with chronic kidney disease. So next thing in the line, so now you have diagnosed chronic kidney disease, right? So the next thing in the line, you need to find out a cause. So you get a good history and do a physical examination and find out more than the physical examination in a patient with early chronic kidney disease. You won't get any physical examination findings. It's the history. Diabetes, if it is diabetes, how was the control? Are you on any medications? Have you had any acute kidney injuries in the past? Have you had any snake bites or leptospirosis in the past? Are you taking any medications? Where are you from originally? Are you from CKDU endemic area? So likewise, you get a good history and find out whether there are risk factors. And then you do a urine analysis, UFR, and also urine ACR, and try to find out the cause. So I'm not going to go into detail about the evaluation of the cause here. It all depends on your history, because there are various causes of chronic kidney disease like autoimmune diseases and myeloma and other stuff. So accordingly, you need to investigate. So without now this is the core of the lecture: how to manage chronic kidney disease in primary care. Okay, so now going back to the basics, you have diagnosed chronic kidney disease by using creatinine, by using UFR and UACR, and you have staged your chronic kidney disease, and you have confirmed your chronic kidney disease by repeating the values, and you have given a try to find out the cause of the chronic kidney disease. So how to manage chronic kidney disease in the primary care, right? So, and so now you have to decide which patients you have to manage in the primary care, right? And which patients you have to refer to the specialist care. So depending on that only, you need to, you can decide how to manage CKD in the primary care, right? So going back to our previous slide. So at this slide, if you go, now
Okay,
you
sir.
can see that, and this
You go to
left-hand
metro
side, you
station
have
or
the
something.
GFR categories. Okay. So you have G1, G2, uh, G3, that is stage 3, and G4 is stage 4, G5 is stage 5, right? You have various stages. And on your right-hand side, you have albuminuria categories, less than 30, which is normal, 30 to 300, moderately increased, more than 300, severely increased. So A1, A2, A3. So we categorize CKD by using both values. G1A1 is this green color box. G2A1 is this green color box, right? G1A2 is this yellowish box. Likewise, we categorize our CKD according to G number and A number. Okay. So now, when to refer this patient to a nephrologist, right? So you put it into this box, and whenever you are having a patient with a very high risk, so that is red color box, or a high risk, so that is yellow color box, sorry, the orange color box, you have to refer this patient to a nephrologist. Very simple. Anybody with an orange or a red color box, you have to refer to a nephrologist. Or if your closest specialist is a physician, you need to refer to a consultant physician who is interested in renal medicine. So to get their opinion. But if you have a nephrologist at your disposal, at these very high and high risk patients, would better be referred straight away to a nephrologist, because they are at higher risk of rapid progression, and they are at higher risk of going into end stage kidney disease very rapidly. So what about people with a yellow color box? So these are a set of people you can monitor at the community, right? So especially when you are familiar with the management of chronic kidney disease. If you are kind of uncomfortable with the management of chronic kidney disease, so then you can refer this yellow color box to a specialist, maybe a physician, and they can decide on the treatment. And if the things are not improving and moving into the orange color box, they can refer to a nephrologist. But the yellow color boxes can be managed in the community, because there are ways, there are things you can do to these patients in the community and see whether there is an improvement of their status by applying those measures. So, but people with green color boxes, you can absolutely manage these people in the community, right? So for example, somebody, imagine a patient with a GFR less than 60, right? So GFR of 50, right? Say GFR is 50, but they don't have albuminuria. So that is G3A A1. So that is the color is yellow. So now you can see albuminuria is a very important marker. But somebody with a G3A, if their albuminuria is very mild, they just move into a high risk group, right? That is orange color books. So you have to refer to a specialist at this point. But other people you can be managed in the community. So what are we going to do for these people in the community? Okay, so that is where we are going to discuss the management of CKD in the primary care. So starting from the lifestyle advice. So somebody might think, this lifestyle advice, there are a lot of things we can say to patients, but they are not going to follow these things. But these are very important things. Only primary care physicians, because you are usually having a good rapport with your patients. You might be their general practitioner in the private sector, you might be their OPD doctor, you might be their family doctor. So usually they are having a good rapport with you. You know your doctor because you have been followed up with your doctor for a long time. So you can have a chat with them and institute these lifestyle modifications. Smoking cessation, one of the most disregarded but extremely important things. Smoking causes rapid progression of chronic kidney disease. Anybody with CKD, they have to stop smoking. So you have to refer them to smoking cessation programs. Maintaining a healthy weight, very important. Obesity is a risk factor for progression of chronic kidney disease. Exercise, extremely important, and healthy diet and salt reduction. So these are important messages you should deliver to your patients. So the next most important thing is a controlling of blood pressure. So controlling of blood pressure is one of the single most important thing you can do to prevent the progression of chronic kidney disease. Usually you encourage them to measure home BP and monitor their blood pressure. So we'll discuss what are the blood pressure goals. And then there are things you can do to delay the CKD progression. We'll discuss them. So what are they? And then stop or review their nephrotoxic medications. NSAIDs, if they are on lithium or sulfasalazine, you have to think twice and see. You get expert opinion whether you need to stop them. And then moving on to the other categories, there are manifestations of chronic kidney disease like changes of calcium and phosphate and potassium, and there are changes of hemoglobin. So there are things you can do in the community to manage CKD according to these aspects, right? So what are the important things about the diet? So there are lots of misunderstanding when it comes to protein intake. Now this slide will bust most of these myths. So what is the normal protein intake an adult should take? It is the number is at least 0.8 gram per kilogram of body weight. So this is the number you have to give even for a patient of CKD 3 up to CKD 5. Okay. So 0.8 gram per kilogram is the minimum amount of protein needed for an healthy adults to survive. Okay. And that is what is needed for a CKD patient. So if you calculate this number, now how do you calculate your 0.8? You multiply it by your body weight. Imagine a patient with a 60 kilogram of body weight, and what's the value? 0.8 into 60, that is 48 grams of protein. Now, if you think about 48 grams of protein, now say how much protein content is there in your chicken. 100 grams of chicken contains somewhere around 33 grams of proteins. Only one third of weight of chicken has proteins, right? So in fish, so it is somewhere around 1/5. So 100 grams of um, fish, or tuna or balaya or whatever the fish commonly available in Sri Lanka, it will contain about somewhere around 20 to 25 grams of protein. That is around 1/5 to 1/4. Now, what about a small, a reasonable size piece of fish? What's the amount of protein content? Somewhere around 6 to 7 grams of protein in one piece of meat or one piece of fish. So, if we are to take a minimum amount of protein to survive as a healthy adult, you need, as I said, 60 kilogram person, you need 48 grams of protein. Now, imagine how many pieces of fish you can eat per day and you should eat. So, that is how many? So, 7 to 8 grams per one piece. So, that is 48 nam about 8 pieces of fish per day. Now, how many of you are eating 8 pieces of fish or 8 pieces of chicken per day? So, very few of you. So, that's the minimum. And that is the amount you need in people with CKD. So what is the myth in CKD? You should restrict protein intake, which is a huge myth because our general population, even you all, are not taking the amount of protein required, not CKD, and healthy adults are not taking the amount required. So what happen if you say to your CKD patient, okay, don't eat meat or restrict your protein? What will happen? They are not going to eat even the minimum amount because they are anyway not eating the minimum amount. They are going to become cachectic and their muscle mass is going to go down and they are going to, their disease status is going to worsen. So never ever tell blank statements to your patients. Okay, don't eat meat, don't eat fish. So what I usually advise to my patients with CKD4 when they ask doctor, should I restrict protein? So what I'm doing, no, don't restrict protein. And that's what I'm telling them because I know most of them are not eating even adequate amount. So if I tell them don't restrict, they will at least eat the minimum amount. So that's where, or even I tell them that you can eat up to 7 to 8 pieces of fish or meat, or else in an egg, you think how many grams of protein are there in a full egg? So that is about full egg 5 to 6 grams. Maximum large egg, it is 6 grams. So you can see how many eggs you can eat per day to fulfill your. So that is somewhere around 8 eggs per day if you want to eat and fulfill your minimum protein intake. So that's why restriction of protein is not a good thing. But so why do we tell these people to restrict protein? Because proteins are being catabolized and there will be urea generating, and this urea is being excreted through the kidney. So if you have loads and loads of urea generating, your kidney is going to do extra work and your kidney function can go down. That is been proven. With extremely high protein diets, your kidney function can go down. But that is from very high protein diet. But there are some guidelines given. If your patient is at risk of, kidney progression very rapidly, especially, healthy, say, like middle age or young adults with diabetic nephropathy with massive proteinuria, if they are having, they are having very high risk of progression, you can cut their protein intake somewhere into very low levels like zero point 0.3 to zero point 0.4. So even if zero point 0.3, now if for a 60 kilogram gentleman, so that is 18 grams of protein, that is somewhere around three pieces of fish or meat. So still you can eat 3 to 4 pieces of fish and meat, or if somewhere around 3 eggs per day. So that's the lowest you can give to a patient with high risk of progression. Now, I hope you understood the protein business. No, never ever tell blank statements. You give by the numbers, and also the other way around. If your patient is cachectic, and your patient is, even if the patient is having advanced CKD, and if your patient is having very low muscle mass, you need to increase the protein intake to a level somewhere around 1 to 1.2 grams. That is a huge amount. So that is about 60 grams of protein, and it might amount to like a 8 to 10 pieces of meat or fish per day. Okay, so that's the diet, the protein intake. BP control, extremely important. So target for people with CKD, we would like to lower the blood pressure less than the usual targets. So if the patient tolerates, you lower the systolic blood pressure below 120, and that's the target, especially with people with proteinuria, and the diastolic BP target is 70. So if you can lower, and if the patient is not getting any postural symptoms, you keep on lowering until these values. But that depends. If your patient is elderly and frail, you might not go down rapidly because they can fall because of postural BP drops. So you might keep their blood pressure somewhere around 130 or 140. But in healthy young males with CKD, not healthy, I mean the young males or females with CKD, you try to lower it again. And what about ACE inhibitors and ARBs? So can't we give this? So that is again another myth. ACE inhibitors and ARBs are, they are renoprotective, and you can give them even up to levels of very low eGFRs, especially in people with albuminuria. Albuminuria is a very bad marker. People with albuminuria progress very rapidly, and you have to give them ACE inhibitors and ARBs. And then, but can you give combination? No, you should never give combination. That is contraindicated. You should never combine ACE inhibitor with an ARB, but you can give single agents, even up to very low eGFRs. So that is going to protect your kidney. There are exceptions which we will discuss. Any other BP controlling drugs? What are the better drugs in CKD? Beta blockers has a better place in people with CKD compared to other people with hypertension. So you can use beta blockers in their very early course, because people with CKD, they are having sympathetic stimulation, and you can reduce the sympathetic drive. And calcium channel blockers and diuretics are also a good way to bring down the blood pressure. But you go by that order. You use ACE inhibitors, or ARBs, beta blockers, calcium channel blockers, or diuretics, right? So next, what are the things we can do to delay the CKD progression? So this is a very important thing. Now, as I said earlier, so ACE inhibitors are kidney friendly. So some of you might think, okay, then why do we ask them to stop ACE inhibitors on ARB whenever somebody is coming with an acute illness, which I will explain to you. Now, what does ACE inhibitor do, or ARB do? Now, in our patient with CKD, they are having, now, for example, imagine a healthy individual who is having 100 glomeruli in their kidney. Now our patient is only having 20 glomeruli because of CKD, because rest of the 80 glomeruli have died. Now these 20 glomeruli have to do a work of 100 glomeruli. So that is the situation. So what will happen? They are going to overwork, and they are going to become tired by overworking. So because of overworking, they are going to die gradually, one by one by one. So that's why if you don't do anything, your chronic kidney disease just progresses. Okay. So your 1.3 creatinine would be 1.5 next year. It will be 2 the following year. Likewise, it will just progress. So you might imagine why the hell this patient is progressing. Simply because the glomeruli are overworking. So what can you do? So what does ACE inhibitor ARB do? It reduces the blood supply to the glomerulus. It relaxes the afferent arteriole. Afferent means atulata, so the afferent arteriole relaxes. So then the blood supply, so the pressure in the glomerulus goes down. So blood supply to the glomerulus goes down. So then what will happen when blood supply goes down, the glomeruli won't overwork. So it will be protected. So that's why we give ACE inhibitors or ARBs to people with CKD. But what will happen when you give ACE inhibitors at the very beginning, their creatinine is going to rise a little bit, as expected, because now these 20 glomeruli are overworking. When you cut down the blood supply to those 20 glomeruli, the creatinine can go up, but that is temporarily. The glomeruli will adjust to the new normal and they will start doing the usual job as time pass by. So that's why their creatinine then slowly, gradually improve back to baseline, and then you just need to patiently wait. Then later on, the ACE inhibitors will protect the glomeruli. Okay. So, but what will happen if that patient comes with an acute illness? So then, acute illness, the demand goes up, and then blood supply will be cut off and it will be diverted to elsewhere, right? The kidney blood supply will be cut off. So, but what will happen if your patient is on ACE inhibitor? Now, already ACE inhibitors have cut down your glomerular blood supply. Now, you are having acute illness, the blood supply further goes down. So then your creatinine is going to go up rapidly and you are going to get an AKI. So that's why you need to stop ACE inhibitors and ARBs whenever your patient is having an AKI. But otherwise, stable CKD, they will benefit from ACE inhibitor. Okay. So especially with people with proteinuria, downside is the hyperkalemia. All right. So the next most important class of drugs to delay CKD progression are called SGLT2 inhibitors. So some of you might be familiar with this set of drugs. SGLT2 inhibitors are called flozins. Your empagliflozin, the dapagliflozin are both available in Sri Lanka. So this is the finding of the decade, because as I said earlier, people with diabetic nephropathy with proteinuria, anybody with diabetic nephropathy, when their eGFR is above 20, should be on a SGLT2 inhibitor. So that's the newest guideline. So you need to be aware of this. You need not to be a specialist to start SGLT2 inhibitor, especially when your patient's eGFR is very marginally high, and whenever you diagnose a patient with having albuminuria, a diabetic patient with albuminuria, with marginally high creatinine, so all of these patients should be on an SGLT2 inhibitor. Unfortunately, these drugs are not available in the government sector yet, but if you start an SGLT2 inhibitor for somebody with an early CKD with mild albuminuria, and if that patient continue to take SGLT2 inhibitor, you are going to surely protect this patient's kidney, and you're going to surely stop them progress to end-stage kidney disease. This is that important. So keep you updated. Please keep yourself updated about SGLT2 inhibitor, and you can start SGLT2 inhibitor in the community and monitor their kidney function and monitor their proteinuria. They will improve rapidly, and these people should be on SGLT2 inhibitor lifelong. And as if I have to remind you, everybody with chronic kidney disease, with diabetes, irrespective of proteinuria, they should be on SGLT2 inhibitor. Even if they don't have proteinuria, they should be on. If they have proteinuria, they should definitely be on. And what about people without diabetes? So people without diabetes, if they are having albuminuria, they should be on SGLT2 inhibitor. These are class 1 recommendations from newest KDIGO guidelines. If your patient does not have diabetes and does not have proteinuria and only having low eGFR, so you might, indication for SGLT2 is little bit doubtful. But anybody else, even without diabetes, if you're having proteinuria, SGLT2 inhibitor is indicated. So what you can do is you start an ACE inhibitor and ARB first and monitor your urine ACR. If your UACR is not improving, you can combine ACE inhibitor with SGLT2 and combined effect will give a better result. So these two measures are the most important things to delay the progression of chronic kidney disease, right? So there are a few other slides, but I can see that I have already passed uh, 1 hour of the presentation, but I will quickly go through the remaining bits of slides. Few things regarding hyperkalemia, because this is very important and you will deal with people with hyperkalemia in the community, and there are myths as well. So how to manage hyperkalemia? So people with chronic kidney disease, they are at risk of getting hyperkalemia, and especially when they are on ACE inhibitors and ARBs, and especially when they are diabetic. So keep these all things in your mind, because you don't people without diabetes, they don't easily get hyperkalemia until their chronic kidney disease progress to a very late stage. Like when their CKD is stage 4 or 5 only, they will develop hyperkalemia. But people with diabetes, they will develop hyperkalemia early, especially when they are on ACE inhibitors and ARBs. But having a potassium of just above 5.1, which is the upper limit, is not an alarming thing. You should not stop ACE inhibitors or ARBs just by having a potassium, below 5.5, because especially if your patient is having albuminuria, because even if your potassium is slightly high, ACE inhibitor ARB are going to confer a huge benefit by controlling your albuminuria. It is going to improve the mortality. So what you should do is, if your potassium is less than 5.5, so between 5.1 to 5.5, what you can do is you can give some dietary advices to these patients rather than stopping your losartan or enalapril. So what are the dietary advices? So you should avoid potassium-rich foods. Again, there are a lot of myths. So what are the potassium-rich foods? So in fact, there are animal foods and the plant-based foods. The famous is, banana. Banana is a plant-based thing. So the truth is, compared to the animal foods, the plant-based foods have a lower impact on hyperkalemia. So most of the fruits, I mean, they do have potassiums in them, but they don't cause huge problems when it comes to hyperkalemia. But fruits like banana and king coconut juice, they usually have the highest amount of potassium. And if your patient is struggling, you might avoid hyperkalemia. But the other fruits usually does not cause much problems if your potassium is, less than 5.5. But if it is persistently above 5.5, most of the fruits might need to be removed. But what are the fruits with lower amount of potassium? So you should know them. Usually, the papaya, uh, guava, pear, gaslabu, and also grapes, and also apples. So these four things contains lesser amount of potassium. So people with chronic kidney disease, they can still eat these type of fruits, because what they have found out ultimately is, if you avoid fruits, the antioxidants and good things coming from fruits are not going to be there, and they are at risk of getting cardiovascular disease because of that. So you should not arbitrarily cut off fruits. And the problem is not really with the fruits, but it's with the animal products, the meat, and especially with processed meats and processed food products like sausages, your sauces, cheese. That's kind of processed food. Animal foods contain loads of potassium, and you should avoid them. And there are a few handy things you can do to reduce the amount of potassium in the food. What you can do, you can soak your raw foods in lukewarm water for 1 to 2 hours, and then all the potassium in the food will come into the water, at least about half of the potassium. And especially the palakola, or your, if possible, your vegetables, the potatoes and things, if you put them in the lukewarm water before cooking, the potassium will be removed. So that's a handy way to remove potassium from your food, and people can enjoy still the fruits and the vegetables by using that method. But if your potassium is persistently high, you might have to adjust the dose rather than completely stopping your ACE inhibitors and ARBs. and also MRS, that is spironolactone. You might have to stop that. And one of the lesser recognized cause of potassium elevation is constipation. So because potassium is excreted through the gut as well, and if your patient is constipated, your potassium, and your patient is having CKD and they are constipated, your potassium can go up easily. So you give some lactulose, and then their potassium will be relieved, then their constipation will be relieved, then the potassium will come down. So, and people with acidosis, you can give sodium bicarbonate, so that will bring down the potassium. So those are the measures you can take to prevent hyperkalemia or aggravating hyperkalemia. A few things regarding, I'm not going to go into detail in the interest of time, calcium and phosphate management. I will keep the presentation shared so you can go through that. And I will tell a few things about anemia management and finish the presentation, because anemia management is very important in people with chronic kidney disease. Um, your people with chronic kidney disease can get low hemoglobin starting from stage 3 to stage 5, and you are not going to start erythropoietin. The ESA means erythropoiesis stimulating agent, that is erythropoietin. So you're not going to start erythropoietin for each and every patient, because some of these people are having true iron deficiency, and you can start some iron tablets for them and give them for a few months and see whether their hemoglobin responds. And especially when their hemoglobin is less than 10, and you give a course of iron to 1 to 3 months, and if at the 3 months, if your hemoglobin is not crossing 10, then that is an indication to start ESA therapy. So what are the cutoffs for iron deficiency treatment? Now you all know there are cutoffs taken from transferrin saturation, that is iron studies, and also from ferritin levels. You can use either of these cutoffs. In a usual healthy person, iron deficiency cutoff is 20. Right? If your ferritin is less than 20, only you diagnose iron deficiency. But chronic kidney disease, your cutoffs are quite abnormal, quite elevated, because people with CKD, they have inflammation, and ferritin is an acute inflammatory marker. So if ferritin goes up because of the inflammation, so usual cutoff is 500. So if your patient with CKD and your ferritin is less than 500, they are having iron deficiency, and their transferrin saturation is less than 30, still they are having iron deficiency. So you can treat them with oral iron and see whether your hemoglobin goes up. And if it is not improving, you can refer to a nephrologist or a physician to start erythropoietin, but otherwise not. And even there, while on erythropoietin, you have to do these ferritin levels roughly 3 to 6 monthly and find out whether they are getting adequate amount of iron, because sometimes your hemoglobin is not improving and you want to increase the erythropoietin dose, but before doing that you do a ferritin, and if there is iron deficiency, you give another course of iron and see whether hemoglobin improves, and usual target hemoglobin is 11. Fine. So basically those are the things, going back to our previous slide, those are the things you can do in the primary care, in the management of chronic kidney disease. Lifestyle advices are very important. You control your blood pressure and delay CKD progression by controlling the albuminuria, by starting an ACE inhibitor or an ARB or an SGLT2 inhibitor, irrespective of their diabetes status, and then the review medications. And then when they are in CKD, you can do things to manage their potassium and mineral disease and also anemia. And so final slide is, what are the things, where are the situations you should refer to nephrologist. So as I said, the previous graph, when the risk is high or very high, you should refer, but there are other indications as well. So when your proteinuria is not getting under control, even if your creatinine is, say, normal, say eGFR is 90, and your proteinuria is very high and not getting control even with ACE inhibitors or SGLT2, you should refer, because this could be something else. some other glomerular disease. Or if your creatinine is rapidly worsening, so this month 1.3, next month 1.5, next month 2, you should refer to a nephrologist to find out a reason. Everybody with eGFR 30. So I repeat it again. Everybody with eGFR 30 need to be referred to a nephrologist because we need to plan uh, rest of the care, the renal replacement and things very early. And if your CKD etiology is not clear, so if your patient is not diabetic, not a hypertensive, not coming from an endemic area, but patient is having CKD, right? And your scan is normal. Now you don't know. And this could be a glomerular disease. So the patient might need immunosuppressant. So you need to suspect if there are no clinical clues, you should immediately refer. And the urinary sediments will help for that. If your patient is having red cells and red cell cast, that might indicate an alarming pathology. You should refer. And if your blood pressure is not controlled with more than 2 agents, you should refer. And if you find out a patient with polycystic kidney disease, you should always refer to a nephrologist because there are drugs which prevent the progression of CKD in people with polycystic kidney disease, special medications. So we should start them. That will only be started by a nephrologist. So these are the indications to refer to a nephrologist. But otherwise, now you can see people with stable CKD and when their cause is clear and their risk is less, and when they don't have albuminuria and their CKD is stable, they can be followed up in the community, right? Especially people with advanced age. So they can be followed up in the community, and you can refer always when their eGFR is, falling or when they are developing proteinuria. But otherwise, so so there are lot of things you can do to diagnose and manage chronic kidney disease in the community, and you can burden the end-stage kidney disease in the community, and you can do a better job. So, thank you very much for listening, and the forum is open to the questions. Thank you very much.
So we have some questions in the chat box. So the
Yeah.
first question is, considering preventing dehydration and or hydration in patients with CKD, how can we objectively advise on daily water intake?
Yeah, so that is a very good question. So, people with chronic kidney disease, so their water retention happens due to two reasons. So, one reason is progression of, you mean dropping GFR, right? So, when their GFR is quite advanced, especially when the GFR falls below 30. So, before their GFR falls below 30, their water excretion usually does not get affected, and they can take the usual amounts of fluids, because usual amount of fluid intake we advise for a healthy individual who is like in the indoor setting, it would be somewhere around 2.5 liters to 3 liters. But if they are working in the outdoor settings, it could be somewhere around 3 to 3.5 liters, especially people who are working in the extreme sunlight. So that would apply people with eGFR above 30. But if your patient is having proteinuria, so they can get edema earlier, even if their eGFR is, above 30. So you know that because of leakage of protein, they can get, oncotic edema. So then it's a bit tricky. So what you can do is, you have to ask the patient to measure a usual day of fluid intake and measure the amount of urine output they are having, and then what you can advise is, if your urine output is above 1.5 liter and people are having this thing called insensible loss, which is around like 750 ml for an healthy adult. So if your urine output is 1.5 liter, you can drink something around 2 liters to 2.2 liters and see whether you develop edema. But if you are developing a bit of edema, you cut down a little bit. So it's like a trial and error thing. So that's how you tell patient with CKD and proteinuria about fluid intake. But otherwise, if they don't have heavy proteinuria and if they have eGFR above 30, it's just normal. Okay. Any other questions?
Yes, sir. There is another one. Should we have to withhold AC inhibitors or ARBs for patients with renal and post-renal AKI?
Absolutely. Yeah, absolutely. So anybody with an AKI, as I said, I hope the message is delivered. Anybody with AKI or suspected AKI, or even anybody who are going to you are suspecting they are going to develop AKI. For example, with a febrile illness. So imagine your patient with chronic kidney disease. Say your eGFR is 50. So they are having very mild chronic kidney disease, but they are going to develop, they get a febrile illness, and patient is coming to you day two fever. So what you should do, you should withhold your ACE inhibitor or ARB. So this is called sick day rule, and this applies to the SGLT2 inhibitor and also your spironolactone as well. So an important message: people with chronic kidney disease with eGFR less than 60, if they are on ACE inhibitor, ARB, spironolactone or SGLT2 inhibitor, and if they are developing a febrile illness or any other acute illness, you should temporarily withhold all these agents and wait until their acute illness weans off, and then you can restart after their creatinine comes back to their usual range. Otherwise, you should keep on omitting them and monitor their creatinine until it comes back to the norm. As simple as that.
Yeah.
So,
While
anything else?
yeah,
Any other questions?
while providing shared care for patients with CKD as primary care physicians, when do you
Yeah.
recommend we should start talking about renal replacement therapy? And
Yeah.
when should a patient with CKD have a fistula created? There are two questions from the same person.
Yeah. So, so the question, answer for the first question, when we talk about RRT for our patients. So it depends on the degree of proteinuria, right? So if your patient is having a UACR above 300, so if you can remember, normal less than 30, 30 to 300 moderately, very high proteinuria 300. So even if your and especially when they're having nephrotic syndrome, like especially with people with diabetes, they are at very high risk of progressing. So if you have seen sometimes people with creatinine of 1.5, 1.6, and your diabetic nephropathy patient and they're having nephrotic stage of proteinuria, sometimes they end up in end stage kidney disease in a matter of 1 year. Mind you, in a matter of 1 year, even less than that. From creatinine 1.5 to creatinine 1.5 to end stage within 1 year, somebody with a nephrotic syndrome. So people with nephrotic syndrome or very high proteinuria, you should never wait. You should refer to a nephrologist at very stage, because sometimes as their creatinine goes up rapidly, we start talking about RRT very early, even when their eGFR is somewhere around 45. So that's what we do. But otherwise, if their proteinuria is moderate, we usually start talking about RRT when their eGFR is less than 30, right? And patients should be referred to AV fistula. Again, it's a like a very subjective question. Everybody with CKD4, stage CKD4, we should consider creating a fistula. CKD4 is when their eGFR is less than 29. So we should consider. So we should talk with the patients, and it all depends on the rate of progression. But anybody with eGFR less than 15, we should create a fistula if the patient, if you have discussed adequately and patient is going to go for RRT. So less than 29, we should think, and even we should think referring to RRT even before that, if the proteinuria is very high.
Okay. Other question is when to start 1-alpha cholecalciferol and calcium carbonate? Can we start it in primary care?
Yeah, absolutely. The answer is yes. So the why we start calcium carbonate and why we start 1-alpha, we should know about that before. We don't just start calcium carbonate for as a blanket to all the CKD patients, and we don't just start 1-alpha to everybody. So calcium carbonate is the first to start. In CKD, the mineral bond thing I didn't discuss in detail in the interest of time. but there are problems happening with regard to the calcium and phosphate. So first thing is to go abnormal is the phosphate. That is because phosphate is being excreted through the kidney. There is not no other good way to excrete phosphate from the kidney. It's only the kidney. So when the kidney starts failing, your phosphates start going up very early. Like in CKD stage 3B, the phosphate starts going up. So first, because phosphate is associated with increased atherosclerotic risk, and you should control phosphate, elevated phosphate in the blood. So then we should bring down the phosphate. So how do we bring down the phosphate? By binding phosphate in the gut, right? So how do we bind the phosphate in the gut? So that is by using calcium carbonate. So we give calcium carbonate not only to replace calcium. So the carbonate component is phosphate binder. So carbonate, so that is by giving calcium. Sorry, the calcium carbonate. So the calcium will bind to the phosphate, and calcium phosphate will precipitate in the gut, and then calcium, the phosphate absorption will be reduced. So that's why we give calcium carbonate. But then in the progression of chronic kidney disease, your calcium will start going down gradually. So then that is also an indication to start calcium carbonate to replace calcium. But otherwise, even if the calcium is normal, you can start calcium carbonate to reduce the phosphate. So then why do we start 1-alpha, or why do we start vitamin D? So 1-alpha is the activated form of vitamin D. So that is called 1-hydroxycholecalciferol. But your usual vitamin D is called cholecalciferol. Cholecalciferol comes as 1,000 international units, 2,000 international units. So we should start cholecalciferol in CKD patients, or even people without CKD when they're having vitamin D deficiency, right? So anybody with vitamin D deficiency, they should be they should be on adequate dose of cholecalciferol, not only having chronic kidney disease. But the problem is, people with chronic kidney disease, this 1-alpha hydroxylation does not happen usually when they are going to the stages of CKD stage 4 or beyond that. So then, by giving cholecalciferol is not going to help them much. So that's where we start 1-alpha to reduce the vitamin D deficiency. But there are other indications to give vitamin D to people with chronic kidney disease, not only to replace the vitamin D. So that is, people with chronic kidney disease, as I said earlier, their phosphate level goes up and calcium level goes down because of the lack of vitamin D in the blood. That is because 1-alpha hydroxylation does not happen because of the chronic kidney disease, right? So active vitamin D is not there. So your phosphate is going to go up and calcium is going to go down because vitamin D is the one which absorbs calcium from the gut, right? So, and as a result, your PTH, the phosphaturic hormone secreted from the parathyroid, is going to go up. So PTH is going to consume the calcium phosphate in the bone and mobilize calcium from the bone, and that is going to cause bone disease, right? So we give 1-alpha or the activated vitamin D in this instance to counteract the effect of PTH. So that's why ideally, to start vitamin D in a patient with chronic kidney disease, ideal setup, we should measure the PTH level. And there are guidelines given according to PTH level to start vitamin D according to PTH level, which I'm not going to discuss because that's beyond the primary care level. And also, on the other instance, you have to do a vitamin D level. So both doing vitamin D level and doing a PTH level is out from the primary care setting, and even it is not available in the tertiary care setting in Sri Lankan setup. So the answer to the question of vitamin D, usually if your patient is in CKD4, we empirically start because most of them get low vitamin D levels because of that, and most of them they will get high PTH levels in that range. So we start vitamin D and CKD4 or beyond. But starting vitamin D before that is a bit tricky in the primary care setting, which I won't advise. But if you happen to do a vitamin D level, and if the vitamin D is low, yes, you can start 1-alpha for a CKD patient and cholecalciferol for a non-CKD patient at any point. So that's the answer. And the other question, what was the next question?
Mm. No, so I think you answered that question, and there
Yeah.
are some other questions as well. The next one is what are the antibiotics that can be given safely to a patient with eGFR less than 40?
Less than 14. Right. Okay.
14.
So that is eGFR less than 14 means CKD 5, right? So now we have to be careful with regard to the nephrotoxic antibiotic. So what are these so-called nephrotoxic antibiotics? So nephrotoxic antibiotics are your vancomycin and gentamicin, right? So that is aminoglycosides and glycopeptides. So they are nephrotoxic in you know especially in the setup of advanced CKD. But what about penicillins, the cephalosporins? Are they nephrotoxic? No, they are not. So, I mean, there are rare instances they can cause acute tubular interstitial nephritis. Any drug can cause kidney inflammation, but we don't take it like that. So, penicillins and cephalosporins are not considered as nephrotoxic. So, you can give penicillins and cephalosporins, carbapenems like meropenem, cefotaxime, ceftriaxone, ampicillin, these drugs you can give safely up to any stages of CKD. But only thing is you have to adjust the dose according to the eGFR. So what you should do is you get your creatinine value, you use your formula, you calculate the eGFR, and then you search the from the internet you can easily get the drug dose according to the eGFR, and you adjust the dose. So by adjusting dose you can start. But what about gentamicin? Is it contraindicated in end stage? No, there is nothing like that. So we do give gentamicin if it is really indicated even for a patient with CKD5, but we have to adjust the dose. There are instances. For example, imagine a patient with CKD5 now having pyelonephritis, right? Your patient had a eGFR of 15, and now because of the pyelonephritis, patient's eGFR is 5. Okay, and your patient's urine culture is only sensitive to gentamicin. Now you think your eGFR is 5, okay, our patient is advanced CKD, we should not give gentamicin to this patient. But the poor patient is having urosepsis and having eGFR 5 because of urosepsis. And if you don't treat urosepsis, he is going to develop end stage. Right, and the only way to prevent that is giving gentamicin, because your drug, the only drug available is gentamicin sensitive. So you should give gentamicin at that instance, but you should adjust the dose. So likewise for the vancomycin, but we generally try to avoid these two if there are any other options. But like penicillins and cephalosporins, they are very safe. Fluoroquinolones, the ciprofloxacin, they are safe. And so those are the drugs which can safely be used, antibiotics, in the setup of renal impairment.
Okay. And what is the frequency of follow-up and frequency of investigation for a CKD patient at primary care level?
Yeah, extremely good question, which I forgot to cover. So people with chronic kidney disease, the guideline is to monitor them 3 monthly. So that's the kind of rough guidance for people with CKD. But it always going to depend on the stage of CKD. But as I said earlier, whenever their eGFR is less than 30, you are going to refer them to the specialist center. So they will be followed up in the specialist center. So this is what I'm talking about is above eGFR 30 to between 30 to 60, right? So you should follow up them 3 monthly. But people with proteinuria, especially when their proteinuria is moderate, initially you should follow up them within shorter periods of interval, maybe like 1 to 2 monthly, until their proteinuria settles to a reasonable level with your medications, with ACE inhibitor, ARB, or SGLT2. So once their proteinuria is settled and you know that their creatinine is stable, then you can follow them up 3 monthly. But otherwise, Yes, so the rough cutoff is 3 monthly, but people with CKD4 in specialist settings, we follow them up still with 3 monthly when their proteinuria is reasonably low. But if they are having heavy proteinuria and CKD4, we are going to follow them up monthly, and all the other patients will be followed up monthly, and so likewise. But in primary care setup, yes, 3 monthly, but heavy proteinuria initially monthly.
Okay. If a patient developed UTI while on SGLT2 inhibitors, how long we have to withhold SGLT2 inhibitors?
Yeah. So SGLT2 inhibitors are known to cause UTIs because the mechanism of action is glycosuria. So there will be increased glucose in your urine, which sometimes you all might think their fasting blood sugar is normal, but urine sugar is positive. That is because of SGLT2 inhibitor, and that's not a problem, and that is not a reason to refer. They will have brick red urine because while on SGLT2 inhibitor. And so the other thing is because of this urine excreting through the glucose excreting through the urine, they are having a preponderance to get UTIs. So once after starting SGLT2 inhibitor, if your patient gets a UTI, that's not a reason to completely stop SGLT2 inhibitor altogether. You should, in the first instance, you should stop it and treat the UTI. Once the patient is adequately cleared, the urine is cleared and asymptomatic, you can give a re-challenge of SGLT2 inhibitor, especially in the person with proteinuria, because you are going to benefit by giving SGLT2. But if the UTI recurs, then that is an indication you might think to refer to a specialist, because there might be any other underlying reason. Because SGLT2 inhibitor itself, they don't cause that much of UTIs as they have been postulated at the very beginning. We are using HGL2 inhibitors extremely common in our renal practice. People don't get UTIs because of HGL2 inhibitor. But if somebody is getting UTIs, there might be, say, underlying bladder malignancy or underlying BPH. They might be having a stone. So likewise, there will be other reasons. So that's why you need to refer to a specialist. But if whenever they are getting recurrent UTIs, you should stop and refer, where we investigate for a cause. If we kind of fail to find a cause, and then we attribute recurrent UTI to SGLT2, then we might have to stop giving it. But otherwise, it does not cause UTI. More than the UTIs, they were known to cause candidiasis. So that's the thing. That is also fairly uncommon. It's not that common, but candidiasis can be sometimes very tricky, quite difficult to eradicate. So in that case, you might have to stop SGLT2. But so that's the management of SGLT2 in UTIs.
If patients develop euglycemic ketoacidosis with EMPHA, can we continue that medicine after recovery of euglycemic ketoacidosis?
Yeah, so that's a very tricky situation because euglycemic ketoacidosis is sometimes be really life-threatening, and it's a you have to refer to a specialist. And sometimes we don't restart if the situation is quite bad. Even if the patient was acutely ill, sometimes we don't restart the SGLT2 inhibitor. It's going to be a risk versus benefit. And imagine there is a patient with eGFR moderately reduced and very heavy proteinuria, and developed first episode of euglycemic ketoacidosis and recovered fully with a careful inspection with an endocrinologist and a nephrologist. We might think re-challenging with a lower dose and keep the dose in a lower range and continue, because the benefits are still higher. But it's a tricky situation. Depends on the person, and it's a very individualistic approach.
What is the best SGLT2 inhibitor for non-DM-CKD?
Yeah. So the studies are done for dapagliflozin. So in non-diabetic CKD, the studies are for dapagliflozin, not for empagliflozin. So at the moment, the guideline says dapagliflozin, but we assume the action is similar, the empagliflozin and the dapagliflozin. So we do start because dapagliflozin is costly. The cost of dapa is quite significantly high compared to empagliflozin. So depending on the patient's affordability, since it is not available, we do start DAPA first if affordable, dapagliflozin. But otherwise, yes, you can start empagliflozin with non-diabetic CKD with proteinuria. But in diabetic patients with proteinuria, you can start either.
Okay. And non-DM patients, what are the doses of AC inhibitors and ARB we can start without dropping blood pressure?
Well, that is a very kind of individual thing. So you should, people with chronic kidney disease, you should start, for example, ARBs or ACE inhibitors from a lower dose. As I said earlier, you are going to knock off some of their GFR at the beginning. So, for example, say eGFR, say around 50 or early CKD, I would start losartan, say from 25 daily, and maybe in 1 to 2 weeks time 50 daily, and try to titrate the dose depending on the proteinuria improvement, because our target is to improve the proteinuria. So then after starting losartan at the very first instance, I would usually do a creatinine in couple of weeks time, especially with people with advanced CKD, not with just eGFR around 50. If their eGFR is say around closer to 30 and we need to start losartan, I would do a creatinine and gradually increase the dose, keeping the creatinine rise anything not more than 25% of the baseline is acceptable. But if the rise is quite big, you might have to go slowly. Come back to 25 again, likewise. But blood pressure dropping is going to be very individual. You never know. So, but the message is the benefit will be highest at the highest tolerable dose of ACE inhibitor. So if your creatinine is stable and your blood pressure is stable, you have to increase to the maximum dose, provided your potassium is okay.
How should we follow up patients on alpha calcidol and in sodium bicarb in community? How frequently should we investigate? What investigations and how to decide?
Yeah, so the monitoring of alpha calcidol, it's very difficult to do in the primary care setting. There are a few things we monitor with regard to the alpha calcidol. Now, as I said earlier, ideally we should monitor PTH 3 to 6 monthly to keep PTH in a kind of a certain level, depending on the CKD stage, which I'm not going to discuss. But what are the what are the results of starting vitamin D or alpha calcidol? So alpha calcidol increases calcium. That is because it is vitamin D, it absorbs calcium from the gut. What happens to the phosphate with alpha calcidol? It absorbs phosphates as well from the gut. So it increases the phosphate in the blood. So this becomes a little bit tricky when we are dealing with a patient with advanced CKD, because now we are trying to bring down phosphate from one side by giving a phosphate binder, but then we need to give vitamin D to counteract the vitamin D deficiency. So when we give a higher dose of 1 alpha, phosphate goes up. So then, we need to increase the calcium carbonate or any other introduce any other phosphate binder to bring down the phosphate level. So it's like a tricky business. So there are other phosphate binders, things like sevelamer or lanthanum carbonate. They are available. So we need to start those stuff to manage phosphate. So the answer to the question how to monitor 1 alpha is by doing calcium and phosphate by PTH. But at least in the primary care setting, you can do calcium and phosphate. So if your phosphate is high while on 1 alpha, so the next step is to increase the calcium carbonate and try to bring down phosphate by phosphate binding. Now, problem comes if your calcium is also a little bit towards the higher side. So then you can't increase the calcium carbonate. Then what you should do is to bring down the 1 alpha dose. So imagine there is a patient who is having CKD and on calcium carbonate and 1 alpha both, and they are having high phosphate and maybe high normal calcium or high calcium. So what you should do is you should bring down the 1 alpha dose to of maybe 0.25 every other day or 0.25 twice a week. So by reducing one alpha, you will bring down both calcium and phosphate. So that's the answer.
Um, okay, sir. And there are some other questions as well. Are red cell casts considered abnormal always?
Red cell casts are abnormal always. That's the answer. It's always abnormal. But the problem is with the just red cells. So red cells are considered abnormal in the UF because red cells are showing a damage, right? But the problem is you might have seen one to two red cells, or few red cells which are very common, especially in females, especially postmenopausal females, because they're having atrophic vaginitis. So they can have a bit of red cells, but not like 15 to 20 of healfuls. They don't get, but one to two, three to four, few red cells, especially elderly female. But in males, even few red cells which are persistent. So whenever you see a UFR report with one to two red cells in a male, you should repeat it. So it might disappear. So that is normal. But if these one to two and then three to four and then 5 to 10 is always there, that is definitely abnormal in a male. But that may be normal in a female. That depends on your degree of suspicion. But whenever you see higher number of red cells, like 15 to 20, or more than that, usually it indicates a problem. These red cells can come from the kidney, or they can come from ureter, or they can come from bladder or urethra. So then there are ways to differentiate between red cells coming from glomeruli versus red cell coming from downstairs. So as you all know, one thing is called dysmorphic red cells. Other thing is red cell cast. So dysmorphic red cells are red cells which are coming through glomeruli, and glomeruli is a very tight, narrow compartment. When they are creeping through, they become dysmorph. Then it will be shown in the UFR. But the problem is, in order to diagnose red cell cast and the dysmorphic red cells, you need a special kind of microscope called phase contrast microscopy, which is not freely available in the usual, setups. So our MLTs, they diagnose these red cell cast and dysmorphic red cells by just using light microscope. Because sometimes things, can be non-specific. What you should do is, whenever you see a significant amount of red cells, like for example 15 to 20 red cell in a male, so you should request for dysmorphic red cells and try to find red cell casts. But if imagine they are not there, but that does not mean these are not abnormal, or that does not mean they are not coming from glomeruli. But if your UFR is showing red cells and you are showing red cell casts and dysmorphic, that shows these are likely coming from glomeruli. So it's like it has a very kind of a positive predictive value, but it's not a very good negative predictive value.
Are we going to advise again red kakulu rice and parboiled rice in CKD? And there is another question. Can CKD patients use whole grain grams? I
Yeah.
combine two
So
questions.
the question here, the question here is with regard to the potassium. So the whole grain rice in the capsule of the grain, it has a bit of more potassium. So that is one problem with the whole grain rice. But as I said earlier, the potassium absorption from the plant-based things is very, very low compared to animal products. So I'm not going to advise against whole grain rice, or it doesn't mean whatever the rice you are going to eat, it's a plant-based thing. It's not going to change your potassium hugely. So that's not a problem. It's the practicality is very less. So you don't advise like that.
When do we have to withhold thiazides in CKD patients?
Very good question. Thiazides, why do we give thiazides to the patients? To control blood pressure, right? We are not going to give thiazides, kind to achieve diuresis. So the blood pressure controlling doses of thiazides are low dose thiazides. Low dose thiazides are 12.5 milligram and 25 milligram. Any dose beyond 25 milligram is not low dose, and that is not given to achieve the hypertensive effect. So don't give 50 milligram thiazide to achieve hypertensive effect, right? So that is lower dose thiazide. So what is the action of thiazide? It acts on the distal convoluted tubule and it reduces the potassium chloride. It inhibits sodium chloride pump and it reduces the absorption of sodium, and then hence it reduces the absorption of water. So you will lose sodium and water in the urine, and you will get a low blood pressure. So that's the mechanism of action. So in order to your thiazide to act, you should have renal tubules, isn't it? So then people with advanced CKD, any degree of CKD beyond CKD4, hypothetically you don't have much renal tubules. So people might think your HCT might not work. So that was the teaching in good old days. But in last few years or so, there are increasing evidence coming that HCT can still be prescribed even for people with very advanced CKD, even CKD5. I mean, not really for people with dialysis dependency, because the action of HCT is not that robust. But people up to CKD5, the thiazides can be given because the mechanism of action, there are other ways of acting, like it acts on the vessels as well and elsewhere. So that's why you can give HCT until CKD5, but only thing is they are not really very strong antihypertensives. So, but you can combine and give until CKD stage 5.
The last question is, what is um, uh, what is recommendation for eGFR calculation formula? It has the question has given a formula, sir. 140 minus age into weight divided by 72 divided by SC serum.
Yeah, so what you're talking about is called Cockcroft formula. So that is the formula we use to calculate GFR. So the estimated GFR is, I think question is regarding estimated GFR, if I'm correct.
Yeah.
So eGFR, you are not going to use that formula, right? As I said earlier, the formula is very, you need not to use a formula, you can use the online calculator. I hope this question is not coming from a medical laboratory technician who is working from the lab, which might be a question for them, but I'm generally talking to primary care set of physicians, because you are not going to use that formula and just easily put that in an online calculator. As I said earlier, if we are to go back to the previous slides, put the eGFR calculator is very easy. CKD, EPI, creatinine equation. Put your creatinine and you will easily get the eGFR. You need not to use any other calculators.
Okay, so with that question, I think we have come to the end of our session. And before we conclude, I would like to remind you all to fill the Google feedback from Google form so that we can give you the CPD certificate. And I extend my sincere thanks to Dr. Buddhika Illeperuma, consultant nephrologist, for sharing his expertise with us. And sir, we deeply appreciate for the time you gave us and the effort and your dedication to this session. And I would also like to take this opportunity to thank you all who joined us today for this important discussion. And now we have, I think it's 11:30 now, and we had a very effective session today. So thank you. Thank you once again. And I wish you all a pleasant evening on behalf of our college. Thank you.
And thank you very much, Sindhuja, and also for you all waiting until late night and with us listening to the lecture. And my thank goes again to the college. And thank you very much. Good night to you.